Hany.
Okay, well, it's my honor to present Professor Dr. Hany Elzahaby, the chairman and head of department and professor of anesthesia, intensive care, and pain medicine at Ain Shams University in Cairo. Professor Hany was a former head of the pediatric anesthesia unit, and he's one of the unique pediatric anesthetists in Egypt. Today, Professor Hany will give us a talk about the pre-medication in children. I hope you all enjoy it.
Thank you, Dr. Hilal. Thank you, Dr. Saad, and I'm really happy to be with you for the second time. Today, I will be talking about a very important and dynamic issue, which is pre-medication in children, and some of the associated behaviors of children perioperatively. So our role is not really only to maintain the physical status of the child, rather than maintaining the mental and social well-being of the child during the whole perioperative period. And definitely it is very important to reduce the distress and anxiety and prevent its long-term consequences. Why do we premedicate children? Yes, for reducing anxiety, for easy separation from their parents, to facilitate mass induction. If we can produce amnesia, that will be great. If there is pain, then analgesia would be the best premedication. And of course, we need to reduce the postoperative psychological problems. Away from the definition, real definition of anxiety, the children, they do get anxious from pricks, from being left alone, from some imaginary fears like a monster will come to them and do whatever, being in unfamiliar surroundings and probably detached from their parents, or maybe if they have previous history of awareness under GA. So there are a lot of reasons that will make them anxious. Many studies try to see what is the percentage of being anxious, of having anxious children in the holding area. This is one of them. Around 13% of children at the holding area have anxiety, and this percentage really increased at mass induction up to 35%. Some studies found more even percentage. Boys are usually having higher scores of anxiety, both during at holding area and at induction. So that's in a questionnaire for consultant pediatric anesthetist in Great Britain. Question about what really happened with if they use primary premedication is enough, secondary premedication, distraction technique, partial physical restraining, whether whole child restraining by parents or by the staff. So most of them reported this is, for below 1 year and then 3 years, usually 3 to 6, and this age of which is common to see anxiety in these patients. So the distraction of the children came first, which is immediately followed by partial physical restraint, whether by parents or by the staff. Then a really big number of whole child restraint by parents. So we are still facing an anxious children that we need to probably partially or doing whole restraining to the child. So anxiety, yes, we know that it increases all these hormones and the epinephrine, cortisol, and blood pressure and heart rate. Not only this physical changes, but there is an association between anxiety and emergence delirium. And this study shows that here children who at the holding area who has low anxiety level, this is an anxiety score, they tend to have less emergence symptoms, and children who has higher anxiety levels, both during holding area and at operating room at mask induction, they have a marked elevation in emergence delirium. Not only emergence delirium, but we can see this is a study that shows the postoperative maladaptive behavior changes that may occur up to like that was studied postoperative day up to 14 days. It starts, the incidence is high early postoperatively, and children with higher anxiety scores, with higher anxiety scores usually have more postoperative behavioral changes. So it is difficult to predict the behavior of the children. Yes, that's true. But we have to work and try to predict the children at risk of getting anxiety preoperatively, which is very important area to look at. Risk factors. Risk factors, of course, preschool children, they have a lot of reasons to get anxious. Pain of injection left alone, imaginations, noises, separations. They don't know what is going to happen. So these are the most common age group that at risk for getting anxiety. Older children, yeah, they know probably the procedure and they are worried about what is going to happen to them. The second risk factor is commonly a genetic one, which is the child temperament. Children who display greater degree of sociability and social adaptive capacities are at less risk to be anxious, and while children who are emotional and impulsive, socially inhibited, they are more likely to have preoperative distress and postoperative maladaptive or negative behavioral changes. Yeah, these are the domains of temperaments. We don't need to go in it. The third risk factor is previous hospital experience. We can imagine that children with previous hospital admission or even vaccination might have more hospital-related fears than other without prior experience in hospital. The fourth risk factor is the parents themselves, the parental anxiety, and it has been consistently associated with the stress at induction. The reason may be explained by a phenomenon called social referencing, when a child look at the parents and take their facial expression and get guided by the behavior they do in unfamiliar situation. Parents at risk of getting anxiety, mothers, unfortunately, mothers more than fathers, and the age of the child less than 1 year, they get more anxious, and of course, if they have previous hospital experience. So manifestations of anxiety, children usually may look like that. They appear scared, agitated. They may breathe abnormally. They may tremble. They probably stop talking or playing. They may cry, even with themselves, or sometimes try to escape. Because in most of the situation, in the best hand, we may look like this picture while inducing mask anesthesia. So how to assess anxiety? that this is a very traditional earlier trait, the state trait anxiety inventory for children, which it's really a very long score and scale, and it needs the children to be answered, to be interactive. So needs an older children more than 5 years, and it takes like 10 minutes. It's not used in clinical practice. This is the most commonly used modified Yale preoperative anxiety scale, sorry, which uses 4 domains: the activity, vocalization, emotions, and the state of arousal. It's a score of 100. Below 30, there is no anxiety, and anxiety increases with higher scores. How to attenuate anxiety? Yes, we all know the pharmacological, the drugs, and probably we'll explore more on the behavioral ways of attenuating anxiety, which may include preoperative preparation programs, interviews, parental presence during induction of anesthesia, and measures that healthcare provider can do. Preoperative preparation, I think, it's mostly now is reduced to a web information. Films that the parents can show to their children, videotapes, play therapy is also effective. Of course, printed materials has almost very little to add. This is advanced program that's all non-pharmacological. It aims at anxiety reduction. It uses distraction at the day of surgery, video modeling, parental presence during induction of anesthesia. They try to avoid excessive reassurance. They sometimes parents are coached, and of course you may make the mask familiar to the children before surgery. This is called advanced preoperative preparation program. It is compared by control and the parental presence and midazolam. It's even at holding area, they appear to be more, it appears to be effective, more effective than midazolam and parental presence, and or maybe equal to midazolam at mask induction. Sometimes when you sit with the parents preoperatively, you may pick parents at risk, because sometimes monitoring patients usually do better, but avoiding parents tends to become more anxious and distressed during induction of anesthesia. I know that a lot of centers practice parental presence during induction of anesthesia. It has social differences among countries and hospitals. There is no real evidence for that it makes big difference, but it helps. Mothers are who are highly motivated to be present at induction anesthesia. They reported high level of anxiety when at mask induction. Of course, benefits maybe you may not give premedication, screaming and struggling on separation is not there. Child anxiety during mask induction, we don't know really if it helps. Long-term behavior changes after surgery, we don't know exactly if just their presence would help in reducing that. Of course, the risk is risks are disruption of our routine, sterility, crowding in OR. Some disruptive behavior may happen, like when a grandmom just at mask induction, she just took the child away, and of course they may get anxious and may get tachycardic, and this shows the parental heart rate from baseline. At mask induction, it increases. We don't know the exact risk of that. It is important that the healthcare providers, whether the staff or the anesthetist or the helping nurse, are trained. When they are trained for distraction and trained how to do non-procedure talk, humors, these all techniques are coping, promoting behaviors, and it helps to decrease the children's distress. Staff who keeps on reassuring the child and apologizing to the child, this is a distress promoting, it wouldn't help. So in summary, that children adapt to stressful situations different from their parents, differs according to their age as well. And of course, some program may help teaching the staff to do distraction, probably of great help. Presence of parents during induction is expected. Sometimes they ask for it. And of course, premedication should be reserved for children whom other strategies have been ineffective. So we do not do routine premedication, pharmacological premedication for all children. Children who received sedatives are less anxious and more compliant than those with parents present only. That was in early 19s. The parental presence offered no additional anaesthesiology for premedicated children. These all are studies. So what is the ideal premedication? Of course, if we have all this, maybe 10 criteria, a drug would have a rapid onset, short recovery, no airway effects, no cardiovascular stable, produce analgesia and amnesia, do not produce paradoxical agitation, simple oral administration, not intramuscular, pleasant and safe, do not produce nausea and vomiting. These are all characteristics of an ideal premedication. The most commonly or the famous one is oral midazolam, given as 0.5 milligram per kg preoperatively, 20 minutes to 30 minutes before induction. Yes, we probably, when we decide to give premedications, a lot of us would give midazolam. We encourage to give midazolam with an apple juice. If we don't have the oral preparation, apple juice. Some people give it with non-steroidal, ibuprofen. Of course, we try to avoid particulate juices, and we specifically avoid grape juice, grapefruit. The second one is ketamine. Yes, in a dose of 4 milligram per kg orally. We all know the side effects of ketamine, but it is effective, especially when we combine both drugs. It helps a lot in fearful child or autistic child. Clonidine and dexmedetomidine appears to be of great help when given like 1 hour before induction. We give it in 4 mics per kg. They appear to decrease the hemodynamic response to intubation. They are not respiratory depressant. They reduce the MAC of sevoflurane for tracheal intubation. They do not prolong anesthesia, especially in procedure more than 13 minutes. They do not increase airway-related complications. Of course, the added feature is that pain scores are less postoperative when using this alpha-2 agonist. This table shows the groups, benzodiazepines, opioid. Of course, if the best premedication in a child who is in pain is giving him a painkiller like morphine, for example, alpha-2 agonist, and of course ketamine. This is a study that compared oral midazolam, oral clonidine, and transmucosal dex. The three appears to have similar sedation scores, similar anxiety scores at parental separation, and yeah, of course, dexmedetomidine and clonidine have less pain scores postoperative. So whatever you do, you may still face a fearful child, an uncooperative child at induction. So what to do is ideally we discuss with a surgeon, we discuss with the parents that the child is not ready, we cannot force him, and of course that scenario doesn't work in many situations. If the case is an oncology case or a cardiac case, some acute conditions, just simply that patients are coming from long distance, a long queue for OR. So all this may interfere with our decision to postpone the uncooperative child. Autistic children, of course, they do not respond well to any new, any change in their routines. They are sensitive to external stimuli, and definitely hospital setting is an anxiety-provoking setup, and a combination of midazolam and ketamine would be of help. So second part or second phenomena is what we call emergence delirium. And we all know that it's non-purposeful agitation, restlessness, crying, moaning, disorientation in the recovery room. The incidence appears to be high with surgery, and even it is there also even in non-painful procedures. It is measured by the pediatric anesthesia emergent delirium scale, which has 5 domains, and the risk factors appears to be the same like anxiety, and anxiety itself is a risk factor. Preoperative anxiety is a real risk factor predisposing for emergence delirium. Same age group, some inhalation anesthetics are more than intravenous anesthetics. Some surgical procedures carries more risk, and of course the child temperament, and if there is pain also that increase. Actually, the rapid emergence and the depth of from the depth of anesthesia really do not predict delirium. So children, again, as we said before, children with high preoperative anxiety are more likely to get emergence delirium. This is very important. How to manage? Preemptive targeting to reduce anxiety, targeting to reduce pain usually works good. Again, a mutual relation between anxiety and delirium. It's not only mutual. The third phenomena are the post-operative maladaptive behavior. They are all interrelated phenomena. So that's when you get a 10% increase in the anxiety scores preoperatively, you tend to get a 10% increase in emergence delirium and about 12.5% of postoperative maladaptive behavior. So anxiety appears to be the real gear behind these two phenomena. A very descriptive high quality research tried to quantify the post-operative maladaptive behaviors in preschool children. A qualitative study. They interviewed 57 parents of preschool children who underwent, their children underwent GA. They interviewed them 10 days after surgery for a detailed behavior of their children, and they went into extensive statistical analysis of the data. And what happened here is really surprising. There is about 67% of children has at least one negative behavior postoperative. That's really a high percentage. They try to group the negative postoperative changes into 4 groups, internalizing problems, behaviors, like separation and anxiety, whether by daytime or at bedtime, specific fears, emotions, regression. They group them as internalizing problems, and the other externalizing problems like anger, frustration, non-compliance, oppositional behavior, aggressive behavior. These are the second group of negative behaviors. And the third group includes feeding or sleeping disruption. So whether sleep disruption, whether having difficulty to fall asleep, or having nocturnal agitation, or even a decrease in sleep duration, or having an eating problem. Sometimes pain or unpleasant physical sensations or fatigue may be there. They named it as somatic problems. Sometimes there is a positive postoperative changes, and most of these positive postoperative changes appears to be related to improvement in the physical condition. For example, patients who are getting a cochlear implant, for example, and they started to hear, so definitely their behavior changes in a positive way. The number of children in their study, it appears that sleep separation and anxiety by night and separation and anxiety by day, and they become more emotional, appears to have higher incidence. And these are the internalizing problems behaviors, the externalizing problem behaviors, the anger and aggressiveness appears to have higher incidence. The feeding problems, nocturnal deprivation of sleep, or eating problems also has higher incidence. And some somatic problems like fatigue and pain may occur. So to conclude, measures to reduce anxiety should be tailored to each child and each family. And the second is anxiety, emergent delirium, and postoperative maladaptive behavior are interrelated phenomena. And I would like to repeat this slide at the end before I leave you, because let's remember that anxiety is the gear behind emergent delirium and the postoperative maladaptive behavior. And thank you very much.
Thank you very much, Dr. Hany, for this lovely presentation, and a very conclusive, actually. I cannot find any questions in the question panel because it's very brilliant talk, but I just have a question for myself. For the dexmedetomidine, how it's would be given and administered to the child himself? Is it oral, or is there any other ways to be administered like?
So the golden rule is not to give intramuscular, of course, not to give rectal. So the golden rule is to give oral drugs for children preoperatively. It's given 4 mics. What happened is, because we don't have clonidine available in Egypt, but we have dexmedetomidine. It's an expensive drug, relatively expensive drug. So we ask, if you have, for example, if you have a list of like 5-6 children, Then we divide it into equal portions, keep it sterile, and then add it to each one. We give it oral 1 hour before. It's not routine to give pre-medications for all, but for example, I find like an incidence of 40 or 50% of children probably needs pharmacological interventions preoperatively. So we give it oral in a dose of 4 mics per kg, 1 hour before operation.
Thank you very much for that. I have another question, if the times allows me. It's a case I faced it once in my life, and I still asking about this. We had a child that he had a midazolam agitation. He was get agitated, more agitated after midazolam, and I don't know if there is anything that we can make better, or we can give something more, or I didn't know. Actually, we ended up restraining him and put him asleep. But I was asking if there is any other options for that one.
Yeah, that report, there are reports of this anxiety, increasing anxiety after midazolam, some reports about that. And I think the difficult child would benefit from combining midazolam and ketamine. So 4 milligrams of ketamine per kg combined with half milligram of per kg of midazolam. You give it with something sweet. You know that we allow now liberal fluid intake, clear fluid intake up to a very close time to operation, so maybe even less than 1 hour now. So sometimes you give midazolam in the room, and then you need to give a secondary. It doesn't work, then you ask the mother, okay, take the child outside, and then here is what you will give him. The nurse will stay with her until she makes sure that the child get ketamine. Usually it works. The second premedication works, yes.
Yeah, we have more 2 questions now. Dr. Hany is asking about any drugs can be given transnasally in the holding area?
Yeah, midazolam can be given transnasally, as I said, the dex as well. The dose is almost half of the oral dose. So both drugs, clonidine, dexmedetomidine, midazolam can be given nasally. It is irritating the child. I mean, no one, even an adult, would not be happy to get drops, nasal drops preoperatively. But it's better than giving it intramuscularly, definitely.
Yes. And another question from Dr. Said Ahmed, he's asking, if low concentration ketamine preparation, how much volume accepted to risk of aspiration?
I mean, to be honest, we don't look for volume, because if it is clear fluid, clear fluids sometimes they said he just got some water just before when you call them, the nurse or the mother would say he just had some water. We do send for the patient and we get him. That's recent guidelines. 1 hour or even zero. They call it zero premedication, zero time premedication.
Oh.
So we don't leave if it's 20 or even 30 mils. That's fine. I mean, sometimes we add to brufen oral premedication, oral non-steroidal. It's sweet and they like it. So it doesn't matter the volume of fluid intake with the premedication.
Thank you very much, Dr. Hany. Thank you very much for a brilliant lecture as well, as usual.